Hello guys, once again Ijaz Hidayat is with you with new talk, with new topic. Today we're going to discuss about the VA ECMO. VA ECMO means Veno-Arterial Extra corporeal membrane oxygenation. Let me introduce myself. The objective of my today's talk is we need to know what is VA ECMO, indication of ECMO, VA ECMO contraindications, cannulations, and management of the flow and management of anticoagulation, weaning process. So let's start. So what is VA ECMO? So VA ECMO is the blood being drained from the venous system. So blood is drained from the venous system and return into the arterial system. So venous and the arterial are the two systems. So from the blue blood which we get taken from the right atrium or from the right heart, from the heart, we take it, purify through the oxygenator, and we return back the oxygenated blood into the arterial systems like ascending aorta. Or in a VA ECMO, actually we provide both cardiac and respiratory support. So with the help of the VA ECMO, we are supporting to the respiratory system and even to cardiac system. So what are the indications? Of course, cardiogenic shock, severe cardiac failure due to any of the following causes. Mean number first is sepsis with the profound cardiac depressions, drug overdose, myocarditis, or reversible cardiomyopathy, pulmonary embolism, and the pre-procedures like post-cardiac surgery, which patients which is unable to wean out from the heart-lung machines. So we give a conventional ventilation support with the help of VA ECMO. Of course, the post-heart transplants, a patient which we transplant the heart, we require VA ECMO in case of the failure of the graft. And this VA ECMO is also the bridge to transplant. So the patients who are on a waiting list, so we can use the VA ECMO as bridge to transplant. So we are buying the time till we get a heart to be transplanted. So what are the contraindications? Of course, this is the gestational age above the 34 weeks, evidence of the severe and irreversible brain damage, multi-organ system failures, consist of the cardiac, lung with the two major organs, uncontrolled bleeding, life-threatening and untreatable pulmonary diseases, immune suppressions, the cannulations. So we're going to talk about the cannulation of the VA ECMO. So the cannulation, there is major three type of cannulations. I'll just show you first. So first is central cannulations. Normally the patients who need to go for the bypass, so with the patient which is difficult to come up from the bypass machines, so we do the central cannulation of the patients. So normally we cannulate the access cannula will be in the right atrium, and our return cannula will be in the ascending aorta for the VA ECMO. But for the neck cannulation, and mostly we use the neck cannulation below than 10 kilogram patients like babies. The access cannula will be right interjugular vein, and the return cannula will be in the carotid artery. So this is the shape how it's going to be cannulated. And the peripheral cannulation is normally for the adult surgeries cases, like with the patients who need to be get adult patients. So we use the peripheral cannulation like a pulmonary vein, femoral vein. We get access cannula, and femoral artery for the return cannula. So peripheral cannula normally we are using above than the 10 kilogram and adult patients. So the access will be the right femoral artery, and the return will be left femoral artery is the ideal for the peripheral cannulations. So see, this is the peripheral cannulation actually, that we are getting blue blood from the femoral vein, and we oxygenate and return back the oxygenated blood into the femoral artery. So for the cannula, with the cannula, chances of distal limb ischemia because of the bigger pipe was inside the pulmonary artery. So there is a chance of limb ischemia. So for that we required a distal perfusion catheters. Cannula is almost like a small size of cannula which was connected with your return cannula, and we perfuse the lower limb of the cannulated part of the patients. So normally the size of our distal perfusion cannula is 7 to 9 French, and the maximum flow we can perfuse the lower limb with the maximum 250 ml per minute, the flow in adults. Less than that, the chance of clotting of the cannula is very high, so we always keeping the cannula like 7 or 9 French, 7, 8, 9 French cannula, but 5 of distal cannula, 5 French distal cannula we can use in a pediatric actually. So this is like, for example, the cannulations, the triple lumen cannulation. So see, this is the for the pediatric 14 French cannula arterial. Then we are taking the retrograde antegrade cannula through the distal length with the 5 French, and the triple lumen venous cannula. So this is the V ECMO, how to do an ECMO. So this is the blue blood from the femoral vein going into the membrane oxygenator with the kinetic force laser machines, where we purify the blood. After purifying the and oxygenating blood, we return back the oxygenated blood to the femoral artery. So usually this Veno-Arterial is used for the heart failure like a patients. The management, of course, flow. The goal for the V ECMO is to provide the patient's cardiac requirements. So the patients below than 10 kilograms, we use the index of 2.8 per minute per meter square, and approximately we perfuse the body 150 ml per kilogram. For above than 10 kilograms, we use a cardiac index of 2.4 per minute per meter square, and the proximal blood we flowing is 120 ml per kilogram. So you will see these three diagrams, and the things to remember is during the VA ECMO sport, two circulation system function is parallel to each other. So this is the thing we need to remember, that in a VA ECMO there is two circulatory system function in a parallel to each other. This is like a need. We return back to the arterial system. So here we have two circulation running, but is with the native heart, it's self circulation, and the other was maintained by the machine. So we have to be careful the time of the VA ECMO patients, that we are maintaining two parallel circulation of the body. So this is the VA ECMO femoral cannulations, oxygenator, pump, blue blood getting from the femoral vein, going into the pump head. From the pump head it push into the oxygenator. From oxygenator it is going into the body. So respiratory failure, the flow competition in the aorta between the recovery of the native heart and the extracorporeal circuit can lead to the Herculean syndrome, or we can say north-south syndrome. This is the major talk of the ECMO, that is at the time when your native heart start recovering, there is a competition of the flow between the aorta, the recovery of the native heart and the extracorporeal circuit can lead to Herculean syndrome. So in case the time your native heart start recovering, this time you have to reduce your ECMO flow, that the native heart can work finely. Otherwise, if you are not going to reduce your the flow of your the ECMO, there is a chance of upper limb will be the blue and the lower limb will be the oxygenator. So normally in the Herculean syndrome, what is happening in the upper part in the respiratory failures, like a recapturing of the heart, deoxygenated blood supply to the upper part of the body, because of the we are not allowing the oxygenated blood to push to the upper body, and our hyper oxygenated blood supply to the lower part of the body in a VA ECMO. So anticoagulations, normally we need a bleedings. There's a two type of bleeding, major bleeding and a minor bleeding. So in a major bleeding, your hemoglobin will fall down to 5 gram. This is a 2 at least 5 gram per deciliter, or 2 gram per deciliter per day. It's mean there is a major bleeding, or 20 mils above than 20 mils per kg per day. It's mean this is a major bleeding. Then of course you require to transfuse to transfusion requirement of 1 time or more of the 10 mils per kg of the RBC. If in case of the minor means below than 20 mils per kg per day, transfusion requirement of 1 times or less, so 10 mils per kg of RBCs. Heparin. So unfractionated heparin, antithrombotic agent, and it is the most widely used systemic anticoagulation during the ECMO. So only 1/3 of the unfractionated heparin bind to antithrombin 3. So it inhibits thrombin after it's formed, but it doesn't normally. To prevent the thrombin formations, so inhibit thrombin already bounded to the fibrin, antithrombin 3. Produced by, see, as you know, the antithrombin 3 is produced by the liver. Target is 30 to 80%. Anticoagulant effect results from inhibit of thrombin factor 10. Infants have low antithrombin 3 compared to the order of children and adults. So if antithrombin 3 activity is below than 30 to 80 considered, FFP need to be transfused to the patients to maintain the antithrombin 3 level. So the antithrombin concentration plasma derived recombinant antithrombin 3. Some center gave it case of the low ACT and antithrombin 10A without checking the level. So hope today's talk gave you some information for the VECMO. Have a nice good day. If you have any queries, questions, please put in, just mention in the comments. We will try to answer you. Have a nice day. Take care. Bye bye.